All right, our next speaker is Dr. Al Khan. He's a member of McLean's research faculty whose work primarily revolves around developmental trauma, depression, and complex PTSD. He's joining us today to speak to the fact that regardless of where we live or what language we speak, people in every country around the world are exposed to potentially traumatic circumstances each and every day. Dr. Khan, thanks for being with us.
Thank you, Sophia, for that fantastic presentation. And I'll try to follow that up with some statistics. And when Scott and I put this program together, the idea was to actually bring some numbers into the foreground to make people kind of think a little bit about what exactly trauma is and the prevalence of trauma globally and what we should consider more often. Very briefly, 40,000 Americans get killed by guns annually. And similarly, in 2020, there were almost 36,000 fatal motor vehicle crashes in the US, resulting in almost 39,000 deaths. However, we wanted to actually bring into focus something that is much more pervasive and something that is a much bigger public health crisis that we're facing and doing, unfortunately, very little about it. So in 2021, approximately 15,590 children and adolescents were diagnosed with cancer, and 1,780 died of the disease. In comparison, in 2020, 3.14 million children were subject of child welfare agency response. 618,000 were substantiated cases, and out of those, 1,750 children died from abuse and neglect. So of all the 618,000 cases, 76% of these victims suffered from neglect alone or in combination with other maltreatment types. So if you go to statista.com and you look at these numbers, you will realize, which is just mind-boggling, that we have been losing 5 children daily from 1998 to 2020. As I was saying, if you go to statista.com and you look at these numbers, you'll realize that we have been losing almost 5 children daily to child abuse and neglect. And even if it doesn't kill the children, neglect is detrimental, as Sophia was talking about, in so many ways. So in its extreme forms, this is a comparison of 2-3-year-old children's brains. It's from the Romanian Orphan Project. And one child has gone through extreme neglect, and one is a normal, healthy brain. So you can see the level of shrinkage that neglect can actually induce in the brain. So these are the biggest health challenges that National Institutes of Health have identified: heart disease and stroke, cancer, opioid addiction, infectious diseases, and diabetes. What if I actually provided you with a slightly different outlook on these biggest health challenges? What if I told you that there is 50% more likelihood to develop cardiovascular disease in later life if you have adversity as compared to having no adversity, no childhood trauma? What if I told you that there's going to be 11% increased risk of cardiovascular disease with each additional adverse childhood experience in your childhood? What if I told you that victims of childhood physical abuse have 49% higher odds of developing cancer? And there is a dose-response relationship. So the more adversity accumulates, the chances of getting cancer are higher. What if I told you that if you had a magic wand and you could wave it and you could get rid of childhood maltreatment, you could get rid of 78% of IV drug use from the society? So this is something that needs to be considered, like looking at diabetes. Adults who have experienced trauma as a child, they have 60% higher risk of diabetes. Similarly, infectious diseases, children with childhood maltreatment have a chronic inflammatory state independent of clinical morbidities. And maltreated children have a 74 to 100% higher risk of hospital treatment. So despite the associations that I just mentioned, it still has not made to the priority areas of the American Public Health Association. And since many of you are here interested in trauma, so I'm sure you're aware of the Adverse Childhood Experiences study and how all that started, but just a little bit of background. So this study started in 1998, 97, 98. They recruited close to 17,000 people, and they have been following them ever since. And this kind of provided us with all the data. Like this study allowed trauma researchers for the first time to quantify the effects of trauma on physical and mental outcomes. So they've been following them ever since. It's a pretty standard 10-item scale. We're looking at emotional abuse, physical abuse, sexual abuse, living with a substance abuser, living with mentally ill family member, witnessing mother treated violently, incarcerated household member, parental separation or divorce, emotional neglect, and physical neglect. And what we have found, and what they found, and what we have replicated a bunch of times now, is the dose-response relationship. So the more adversity there is, the more risk there is, and the more severity there is. So here you can see these are separate studies by the same group, where you can see that like the more adversity results in more depression, more incidence and prevalence of depression, more severity of depression, similarly for IV drug use, and similarly for attempted suicide. One mind-boggling finding that came out of the same study was actually, if on the same scale you have more than 6 adversities, if you have endorsed more than 6 adversities, that potentially resulted in a nearly 20-year reduction in the lifespan. And what people have been looking at that, and they've been looking at the cardiovascular risk and all that, and they've realized that it has a lot to do with the fact that adverse childhood experiences, childhood trauma, actually puts you on a path of risky behavior, and that ultimately results in a reduction in lifespan. So that was that study, the A study, is being replicated in multiple ways. The 2011 Behavioral Risk Factor Surveillance System Survey has integrated the ACE into its core survey components, and they've been following like close to 50,000 people. And as you can see, time and again, the ACE score of more than 4 gets associated with like so many issues which were considered as matters of public health concern. So this makes childhood abuse, childhood trauma as a critical missing factor in the context of public health. And it's this the same scale, but I wanted to actually the same graph that I showed, but I wanted to actually emphasize a few key statistics here. And that is because if you could potentially, that's why we call it the most preventable risk factor for mental health disorders. If you could remove childhood trauma, because so the PARF means population attributable risk fraction, and if you could like remove childhood trauma from the society, you could get rid of 54% of depression. You could get rid of 45% of childhood onset psychiatric disorders. You could get rid of 78% of IV drug use. And you may have noticed suicide as one of the key public health concerns. And the thing is, if you could get rid of childhood trauma from the society, you could get rid of 64% of suicide attempts. Specifically talking about children, this is a relatively recent graphic from the Adverse Childhood Experiences and NSCH data. And the dose response is seen here as well when it comes to children and their general presentation. So the purple is the 4+ ACEs. And as you can see, a child who has no adversity, and so there is a 14.3% risk of developing needing special healthcare needs. But in comparison, someone who has experienced 4+ adversities, the risk is actually 43.5%. Depression, if you can, someone who has no adversity, a child between ages 3 and 17 who has no adversity, the chances are 1.3% as compared to 19.4% for someone who has been through 4+ adverse experiences, right? And even in the general context, let's not talk about psychopathology. Just look at the difficulty making and keeping friends, 16.3% versus 41.5%. And again, like in all of these graphics, the dose response is pretty clear. The economic cost is staggering. The national health spending is projected to grow, and it will reach 6.2 trillion by 2028. So if you look at all the disorders that the National Health Institute had outlined as key reasons of concern, the key challenges, all of those disorders are associated with childhood adversity in one way or another. So it kind of contributes to all the healthcare spending. When they looked at the substantiated and unsubstantiated cases, and they did an economic cost analysis, they realized that childhood abuse was actually costing the US economy $428 billion. And when they looked at the unsubstantiated cases as well, just looked at the annual incident cases, they realized that actually the estimated burden was close to $2 trillion. So this is by the American Public Health Association. And I wanted to just very quickly mention this. These are the social determinants of health that the American Public Health Association have outlined. And as you can see, education, housing, income, and then like poverty, level of graduation, parental level of education, all of these things are very relevant in the US. But if you take the same psychosocial determinants and you apply them in a global context, they just get augmented significantly. So let's talk about the global situation a little bit. 90% of the world's children live in low and middle income countries. And we know through UNICEF and WHO that 1 in 2, so half of the world's children, actually 1 billion children ages 2 to 17 experience violence in in the form of directly experiencing it, like physical, sexual, and emotional abuse, or indirectly, which would be being a witness to domestic violence or experiencing violence themselves. In the schools, in the communities, every year there are an estimated 40,000 homicide deaths globally. 3 in 4 children aged 2 to 4 regularly suffer physical punishment or psychological violence at the hands of parents and caregivers. 1 in 5 women and 1 in 13 men report having been sexually abused as a child. So this is kind of like a global, and a lot of people have said that this is primarily an underestimate because of underreporting. So given these numbers and the prevalence of childhood maltreatment and the associations that we just talked about, it is unsurprising that mental disorders are the leading cause of disability among children and adolescents globally. Back in 2010, the WHO group, the World Mental Health Survey group, they looked at associations between childhood adversity in 21 countries, ranging from high income to low income, all the way to low income. And they looked at childhood adversities and mental health. And they found out that childhood adversity actually accounted for 30% of all the disorders across all groups of the World Mental Health countries. And more specifically, maladaptive family functioning, which would be childhood abuse and neglect, parental mental illness, were the strongest predictors of disorders. So that means that actually childhood maltreatment is a critical missing factor in the context of global public health as well. And also, it's a critical missing factor in the context of global mental health. So specifically, to give you an example, if you look at trauma and PTSD, they recently did a survey, recently reanalyzed their survey findings. I think the paper came out in 2017, 2018. And by then they had added more countries. And so the World Mental Health, the WHO World Mental Health Group, they looked at 70,000, close to 70,000 participants from 24 countries. And they looked at 29 lifetime traumas. They evaluated for PTSD twice. And they found out that up to 70% of respondents experienced some form of lifetime trauma. And exposures averaged 3.2 traumas per person. And there was a PTSD burden of 77.7% per 100 respondents. So if you look at childhood trauma, and then you look at PTSD and predisposition to PTSD, there is a whole line of research that suggests that if you have a childhood trauma, these bigger traumatic, more recent traumatic events are going, the risk of PTSD substantiates, it increases if you are predisposed to it because of childhood adversity. So I also wanted to talk a little bit about the trauma and its sequelae in special populations. So currently, close to 90 million people are displaced, and out of those, 36.5 million, which makes 41% of the population, are below 18 years of age. They are children. And 1.5 million children have been born as refugees in the past few years. So From the previous slide where I mentioned that there was an average across 24 countries, there was an average of 3.2 traumas endorsed. Refugees actually report a mean of 11.2 different self-experienced traumatic events. That's why 1 out of 3 asylum seekers and refugees experience high rates of depression, anxiety, and post-traumatic stress disorder. They did a study in the Syrian children in a refugee camp, and they found out a prevalence of 26% PTSD in those aged 6 years and younger, and 33% in those aged 7 to 14 years. In another study, they found out that families who had fled war zones in Iraq and Syria had like 30% of them, 1 out of 3 children displayed symptoms indicating PTSD. And another study has actually found a prevalence of that the mental disorder prevalence rate is 10 times higher in refugees settled in Western countries. So if you look at the APA findings and generally speaking across multiple literature, you will find out that approximately 50% of refugees suffer from some form of mental disorder. And a key thing here to notice is also that children of refugees exposed to parental PTSD are at increased risk of psychiatric morbidity. So as I was mentioning, according to APA, the mental health disorders for this population vary widely, anywhere from 20% to 80%, depending on the study and the setting. And the refugees also go through multiple traumas. Like, for instance, if we focused on, let's talk about, let's say that the people who have recently immigrated to the US from Afghanistan and from Ukraine and all that. So there are multiple factors which augment the effects of the trauma, which is called the post-migration trauma, which is the stressors of poverty, insecure housing, unemployment here, feeling isolated here because they have been plucked out of where they were from their own culture. Then they have to go through stressful legal issues, poor access to services. And there is adequate research now that shows that the number of risk factor accumulates for children. As the number of risk factors accumulates for children, the likelihood that they will develop psychological disturbance dramatically increases. So this is important for us from a specific point as well, and that is identification. So there is this problem of the gatekeeper effect. So first and foremost, there is the stigma. So refugees don't come forward with psychiatric disorders or psychiatric issues, even if they are suffering from it. And then primarily, like if you look at it here from, this is from the APA, the graphic, and they found out that basically a PCP visit only resulted in refugees getting referred for mental health services. 3% of the refugees got referred for mental health services from PCP clinics. So there is the identification component there as well. There is not coming forward, the not coming forward factor as well. And so this is primarily, like we are talking about, overall refugee population. Then if you reduce it to just the children, you will realize that it becomes even more complicated to first identify and then address their issues. So in summary, I would like to end on a positive note. WHO has been working on this. There has been steps. The Sustainable Development Goals, so 16.2, prevention of violence against children globally, and to be able to achieve it by 2030 is a very, very ambitious, but a goal worth, it's a very ambitious goal, but a goal worth pursuing. And preventing child maltreatment before it starts is possible, but it requires a multi-sectoral approach as per WHO. And they have this model, you can go to their website and they can, you can find it. It's called INSPIRE, and 7 strategies for ending violence against children. And that has, the INSPIRE stands for implementation and enforcement of laws. So there needs to be laws, and there needs to be implementation of laws. So in 90% of the world's countries, there is some form of a law against corporal punishment, just to give you an example. But how much of that is implemented is a question for debate. Similarly, norms and values. So many of you might have come across this news that I think it was in Missouri. they, I could be wrong, but one state recently made corporal punishment in the US legal again, if parents allow that, right? So the norms and values need to be significantly re-evaluated. You need to provide safe environments. So child labor is a form of childhood abuse. You need to consider all these things. Parent and caregiver support. So there is a long line of research which shows that, like, if a mother is antenatally depressed, the chances of the child getting maltreated is going to be significantly higher. So the parent needs to be supported, the caregiver needs to be supported. Income and economic strengthening. There is no doubt based on research that poverty and these psychiatric sequelae are interconnected. Poverty and violence are interconnected. So that helps. Response and support services also need to be in place, also need to be constantly updated according to the policies. And education and life skills. So education to the parents, education to the children about what their rights are. So, like, for instance, in India, there was a program a couple of years ago where they wanted, they actually tried to teach children what is privacy, what they should do if someone touches them in public in some inappropriate way. How can they know their boundaries and all that? So children need to be like, this does not need to be a sensitive topic anymore. We need to actually explain to the children what it is, what can happen, and all that. And that's why it's going to require a multi-sectoral approach on so many levels. And like, as I said, some might argue that this is very difficult, but there is strong evidence over the past 2 decades that childhood maltreatment is the most preventable risk factor for psychiatric disorders. And on that note, thank you.
Time for Q&A. We got some really good ones here. You ready, Al?
Yep.
All right. One thing I do want to say is thank you so much for bringing up that refugees they often experience traumas after being displaced as well. It's not that you're relocated or you're living somewhere else and all of a sudden things are great. There's so many other things that are happening that can be essentially just as bad, sometimes unfortunately even worse, depending on your new situation. So thanks for bringing that up. So someone said the image of the neglected versus non-neglected child's brain was very striking. Is there any research on how much of the neurological effects are the result of the physical aspects of neglect versus the psychological aspects?
So this image, there is a researcher at Harvard School of Public Health who has done a lot of work on child nutrition. And she once told me, and the next presenter, Dr. Wahab, actually knows her quite well. So she once told me, Dr. Aisha Yousafzai, that they use this image basically to convince mothers in low resource settings that this is what could happen to their children if they don't provide them with sustenance. So emotional neglect is very difficult to capture. This was physical neglect, the image. And we look at neglect all the time. And to be honest, looking at the research, knowing a little bit about it, I would say that emotional neglect is it presents itself differently and a lot more psychologically as compared to what I just showed you. And as I said, like, it was an extreme presentation, but just to make the case that this is what neglect could look like. Yeah.
Thank you.
Yeah.
So it seems that many people have different ideas of what constitutes childhood abuse. Would you be able to share the definition that studies often use to define
it? Sure. Let me actually, can we take this question at the end so that I can show the WHO definition?
Absolutely.
Yeah.
Something else that you said was that 50% of refugees have an identifiable mental health disorder, but only 3% of them are referred to see a mental health provider. Is there something that can be done or something we should be doing? Is anybody coming up with some kind of an intervention around the people that are seeing refugees in order to make sure that they're able to better identify disorders in the people that they're treating?
So it depends on the context and the place. So, like, are we talking about in the United States or globally? Because globally, like, again, this is a debate about the resources. So, like, if you look at the global situation, out of the 89 million refugees, most of them are actually in neighboring countries. So Pakistan is severely under-resourced. Pakistan right now, 1/3 of it is submerged, but at the same time, it has close to like 1.3 million refugees from Afghanistan. So unfortunately, you have to depend on UNHCR. Unfortunately, you can, because you're just under-resourced, right? Here, it's a different matter altogether because you have to be open to these possibilities. You have to be open to the, like, if you know that they could be having this problem, then you are a little bit more aware that, okay, like maybe what this person is showing is, it has to do with trauma. It has to, so just being open about these kinds of things. And like, again, different contexts. So low resource context, there is a lot you can do. You want to do, but you can't. And then here, it's a different thing. But as like, for example, like I talked about the gatekeeper effect. So APA talks about it, right? So if you are a primary care provider, just be open to the possibility that this person might be having mental health issues.
Thank you. Lisa wrote in with a great comment question. We're currently working with a family from Afghanistan, and they seem to not have an understanding of mental health, emotional pain, and trauma. It seems to be a foreign concept to them, and she's wondering if this is common.
Okay, so I will defer that question to my next presenter because he's going to talk specifically about this. And yes, this is very common. And so, having worked in Pakistan for a while now, the thing is, there is a 90% treatment gap. It has a lot to do with the lack of resources, but it also has a lot to do with the lack of awareness. So, and even in educated, like I was doing an intake for someone, and it was a very well-educated guy the other day from a high-income country, and he just didn't want to get treated for his depression, even though that was severely debilitating. And then I asked him, what if you had a cardiovascular disease, you were diagnosed with a cardiovascular disease 2 days from now, would you start medication? And he said, right away.
One more question for you, and then we're gonna go.
Sure.
See. Here we go. As someone who works in global health, the scale of the challenge is staggering. Are there scalable models of care that could help address this challenge?
Again, a little bit, it has a little bit to do with the context, right? So are we talking about the refugee crisis? Are we talking about the childhood maltreatment? Because we have to give them some credit. Yes, they have universal models, which are not applicable like in the global context. In some places they work, in some places they fail. But WHO have standard guidelines, and they keep updating those. So there is the image gap for low resource settings, right? Then UNICEF is doing some very good work on child protection. So we have to give them credit where it is. UNHCR is doing fantastic work on the refugee crisis. But just think about the fact that 89 million people, it's just staggering. So in terms of global models, yes, there are. Whether they are going to work in the setting you want to apply them, possibly it is worth trying, but yes, there are global models. Yeah. And it is staggering. Yes. There's no doubt about that. Yes.
Last question. You touched on the likelihood of developing cancer as it relates to childhood. Would you just repeat that for everybody so they can
the slide?
Yeah, or you don't even, if you can just repeat the information if you know it offhand.
Absolutely. So I have to actually kind of make it a little bit clear. So there is the biological predisposition, the genetic factors, the genetic loading, and then there are risky behaviors. So a lot of the stuff that happens, so cardiovascular risk and all of those things. So we are doing a study right now on recently recovering drug abusers and their childhood maltreatment history, and none of them actually have had a perfect childhood. So that's something to consider, because what happens is adverse childhood experiences, physical abuse has been shown to be very strongly related with alcohol use disorder, to smoking, to drugs and all that. So these put you on the trajectory to do all these things. Specifically speaking, if you want to get into the specifics, yes, childhood sexual abuse has been specifically associated with cervical cancer in women. You can, there is research on that. So childhood maltreatment is the abuse and neglect that occurs to children under 18 years of age. It includes all types of physical and or emotional ill treatment, sexual abuse, neglect, negligence, and commercial or other exploitation. which results in actual or potential harm to the child's health, survival, development, or dignity in the context of a relationship of responsibility, trust, or power.
Al, thank you so much. I really appreciate it.
Absolutely. Thank you for having me.